am going to talk about loop diuretics, the mechanism of action, pharmacological effects, clinical uses and adverse effects of loop diuretics. Loop diuretics have the capacity to inhibit sodium-potassium chloride co-transporter acting at the thick ascending limb of loop of Henle. These drugs are known as highly efficacious diuretics or high-ceiling diuretics. But why? In the figure, as we can see, 67% of the filtered sodium is reabsorbed at the proximal tubule. The solutes that are rejected by the proximal tubule reaches the thick ascending limb of loop of Henle, where 25% of filtered sodium is reabsorbed into the interstitium. The remaining 5% of the filtered sodium reaches the distal tubule. So the nephrons of thick ascending limb of loop of Henle have high reabsorptive capacity compared to the nephrons of the distal tubule. Therefore, diuretics acting at the thick ascending limb of loop of Henle cause greater excretion of solutes, that is sodium, potassium, chloride, compared to the diuretics acting at the distal tubule. Since the extracellular fluid depletion caused by loop diuretics is much greater than the fluid depletion caused by the diuretics acting at the distal tubule, these diuretics are known as high-efficacy diuretics or high-ceiling diuretics. The drugs in this group are furosemide, bumetanide, ethacrylic acid and torsemide. Furosemide and bumetanide are sulfonamide derivatives. Bumetanide is 40 times more potent than furosemide and causes lesser side effects compared to furosemide. Ethacrylic acid is phenoxyacetic acid derivative and it can cause hepatotoxicity and ototoxicity. So it has gone out of use. Torsemide is 3 times more potent than furosemide and is longer acting. So now let's move on to the mechanism of action and site of action of loop diuretics. So let's look at the ionic movement across the tubular epithelial cell. So the figure here shows the tubular epithelial cell which has two membranes, the basolateral membrane which faces the interstitial side and the luminal membrane which faces the lumen. There is a transporter which functions on the luminal membrane, that is, it transports sodium, potassium and chloride from the lumen into the epithelial cell. It is known as symporter because the movement of the ions are in the same direction. It is an active transport mechanism because it requires energy. So where does it get energy from? It derives energy from the sodium-potassium ATPase pump which functions at the basolateral membrane, pumping sodium out and potassium inside. So this creates an electrochemical potential gradient which drives the ions, that is sodium, potassium, chloride, into the epithelial cell from the lumen. The potassium that enters into the epithelial cell moves out through large conductance channels which functions in the luminal membrane. Since positive charges are moving outside into the luminal membrane gets hyperpolarized. But the chloride ions, which are the negative ions, the chloride ions move out through the chloride channels which are present in the basolateral membrane. Now since the chloride ions, which are the negative ions, are moving out through the chloride channels, the membrane gets depolarized. So the luminal membrane gets hyperpolarized and the basolateral membrane gets depolarized. So this creates a trans-epithelial potential difference of minus 10 MV, with the lumen being more positive with respect to the interstitial space. Now since the lumen is positive, it repels the cations such as calcium and magnesium and provides a driving force for the movement of calcium and magnesium into the interstitial space. So calcium and magnesium are reabsorbed into the interstitial space and sodium and chloride also enters into the interstitial space. So what happens when a loop diuretic is administered? The loop diuretic has the capacity to inhibit sodium-potassium chloride co-transporter which functions at the luminal membrane. Due to inhibition of the transporter, the inward movement of sodium-potassium chloride is inhibited. So this decreases the reabsorption of sodium chloride and potassium, causing excretion of sodium chloride in urine. Also, the transepithelial potential difference is abolished, and because of the abolition of transepithelial potential difference, the calcium and magnesium reabsorption is blocked. So this causes increased excretion of calcium and magnesium in urine. Also, some of the diuretics which are derived from sulfonamides have a weak carbonic anhydrous activity, and because of carbonic anhydrous inhibiting property, they cause increased excretion of bicarbonate in urine. So what happens to the potassium excretion in urine? Because of increased delivery of sodium to the distal tubule, there is increased excretion of potassium and hydrogen into the lumen, and this decreases the potassium levels in the body, causing hypokalemia and increased potassium excretion in urine. Also, the loop diuretics stimulate the renin-angiotensin system, causing increased aldosterone formation, which increases the sodium and water absorption and causes increased potassium excretion. So potassium excretion is due to increased delivery of sodium to the distal tubule, and also because of the stimulation of renin-angiotensin system causing aldosterone formation. What happens to the uric acid excretion? Acutely, loop diuretics increase the uric acid excretion in urine. However, chronic administration can cause hyperuricemia or increased blood levels of uric acid. Now, the reasons being there is increased proximal tubular reabsorption of uric acid. Secondly, there is also increased uric acid reabsorption secondary to volume depletion caused by loop diuretics. Thirdly, there is competition between the diuretics and the uric acid for the transporter that operates at the proximal tubule and is responsible for the excretion of uric acid. So, the loop diuretics, by binding to the transporter, inhibits the excretion of uric acid into the lumen, and this leads to accumulation of uric acid levels in the body. Hyperuricemia due to chronic administration of loop diuretics is due to increased proximal tubular reabsorption, increased uric acid reabsorption secondary to volume depletion, and thirdly, competition between the diuretics and the uric acid for the transporter that operates at the tubule, thus inhibiting the excretion of uric acid into the lumen. So these are the factors that lead to accumulation of uric acid in the body causing hyperuricemia, and this happens because of chronic administration of loop diuretics. Lastly, loop diuretics impair the kidney's ability to excrete dilute urine. This is because the ascending limb of loop of Henle is a part of the diluting segment. It is impermeable to water, but it reabsorbs sodium and chloride. Since it is impermeable to water and reabsorbs sodium and chloride, it excretes a lot of dilute urine. So loop diuretics, by inhibiting the sodium chloride symporter, causes increased excretion of solutes in urine, and this impairs the kidney's ability to excrete dilute urine. So to sum up the effects of loop diuretics on urinary and excretion, there is increased excretion of sodium, potassium and chloride in urine. Also, there is increased excretion of calcium and magnesium in urine. Acutely, loop diuretics cause uric acid excretion, but chronic administration leads to uric acid accumulation in the body causing hyperuricemia. So what are the other effects of loop diuretics? Effects on renal hemodynamics. Loop diuretics have the ability to increase the renal blood flow. This is due to increased prostaglandin synthesis, which causes dilatation of renal blood vessels, thus increasing the blood flow to the kidney. Secondly, the loop diuretics can block the tubular-glomerular feedback mechanism, thus increasing the renal blood flow to the kidney. So what is tubular-glomerular feedback mechanism? The solutes that leave the loop of Henle reaches the distal tubule. The macula densa of the distal tubule senses the sodium and sends a signal to the afferent arteriole to constrict and decrease the renal blood flow. The loop diuretics can inhibit the salt transport in the macula densa, so the macula densa is no longer able to detect or sense the sodium in urine, and so the tubular glomerular feedback is blocked. Due to blockade of tubular glomerular feedback, the renal blood flow increases. Thus, loop diuretics increase renal blood flow by increasing the prostaglandin synthesis and by blocking the tubular glomerular feedback mechanism. So the next effect, the loop diuretics have direct vascular effects. Due to prostaglandin synthesis, they can cause dilatation of blood vessels. So due to increased venous capacitance, there is decreased peripheral vascular resistance and peripheral pooling of blood. So this decreases the left ventricular filling pressure and reduces the symptoms of pulmonary edema. So the symptoms of pulmonary edema is reduced due to decrease in the left ventricular filling pressure even before the starting of diuresis. Thus, loop diuretics benefit patients with pulmonary edema by decreasing the left ventricular filling pressure and by causing diuresis and decreasing the congestion in the lungs and periphery. Loop diuretics have the ability to inhibit the salt transport in tissues other than kidney. For example, inhibition of salt transport in the inner ear causes alteration of electrolyte composition in the endolimb of the inner ear. So this can cause ototoxicity. Ototoxicity can be manifested as deafness, fullness of ear, vertigo, and it becomes irreversible in presence of high doses or rapid IV administration of loop diuretics, or if loop diuretics are concurrently administered with other ototoxic drugs such as aminoglycosides, vancomycin and other antibiotics. So next, what are the important pharmacokinetic features of loop diuretics? The average oral bioavailability of furosemide is 60%. In contrast, bumetanide and torsemide have higher bioavailability. So the absorption is better than furosemide and they are longer acting. In terms of elimination, furosemide is extensively bound to plasma proteins and this acts as a hindrance to glomerular filtration because only the free drug is filtered through the glomerulus. But loop diuretics are efficiently secreted into the proximal tubule via organic anion transporter which mediates the transport of furosemide into the tubular lumen. Thus, loop diuretics undergo excretion through the kidney by tubular secretion. Therefore, in patients with renal disease, the T-half is prolonged. Bumetanide and torsemide, however, undergo significant hepatic metabolism, so the T-half of these drugs is prolonged in hepatic disease. Since the T-half of furosemide is very short, as the effect of the drug decreases with each dose, the nephrons avidly absorb a large amount of sodium into the body, leading to post-diuretic sodium retention. So post-diuretic sodium retention occurs when the effect of the drug declines due to decreased concentration of drug in the tubular lumen because the T-half of furosemide is very short. So this drawback can be overcome by increasing the frequency of administration of furosemide and secondly by restricting sodium intake. So now that we have learnt about the pharmacological effects of loop diuretics, so let us now discuss the clinical uses of loop diuretics. The loop diuretics, because of the diuretic effect, are very useful in the management of clinical edematous condition. For example, in acute pulmonary edema, the loop diuretics decrease the symptoms by decreasing the left ventricular filling pressure and causing diuresis. So this helps in reducing the symptoms of pulmonary edema. They can also reduce the symptoms of chronic congestive heart failure and minimize venous and systemic congestion. This can reduce hospitalization rates and improve the quality of life of the individual. The edema associated with nephrotic syndrome is refractory to less potent diuretics. So loop diuretics are highly potent diuretics and are capable of reducing massive edema. The edema and ascites associated with liver cirrhosis can also be treated with loop diuretics. The loop diuretics treat edema associated with chronic kidney disease and converts oliguric renal failure to non-oliguric renal failure by increasing the urinary flow rates. The next use is Loop diuretics can be used for the treatment of hypertension, particularly if it is complicated by renal impairment. However, thyroid diuretics are preferred as antihypertensive agents which is not associated with kidney disease. In terms of non-diuretic use, because the loop diuretics increase the calcium excretion in urine, it can treat mild to moderate hypercalcemia. So lastly, let's talk about the adverse effects, precautions, contraindications and drug interactions of loop diuretics. Loop diuretics deplete total body sodium and this decreases the extracellular fluid volume causing hypotension, circulatory collapse, thromboembolic episodes. In patients with liver disease, it can cause hepatic encephalopathy. Next, loop diuretics can increase secretion of potassium into the tubular lumen causing hypokalemia. And hypokalemia is a risk factor for cardiac arrhythmias, particularly in patients with cardiac glycosides or when the potassium intake is insufficient. The loop diuretics are also known to increase the excretion of calcium and magnesium in urine, causing hypocalcemia and hypomagnesemia. Hypomagnesemia is a risk factor for cardiac arrhythmias and hypocalcemia in long term can lead to tetany. Next, chronic administration of loop diuretics can also lead to accumulation of uric acid in the body causing hyperuricemia and occasional gout. Next, loop diuretics can cause hyperglycemia due to inhibition of insulin release. So this effect can cause precipitation of diabetes mellitus. The loop diuretics are known to cause ototoxicity when administered with ototoxic drugs such as aminoglycosides, cisplatin because they exhibit additive ototoxicity. Loop diuretics can also cause alteration in lipid profile. They can increase the levels of LDL, cholesterol, triglyceride and decrease the protective cholesterol that is HDL in the body. This can lead to increased risk of cardiovascular events in long term. Skin rashes and photosensitivity can also occur with the use of loop diuretics, particularly which are derivatives of sulfonamides. So coming to the drug interactions, loop diuretics can enhance digitalis toxicity because they cause hypokalemia and hypomagnesemia, which are risk factors for cardiac arrhythmias. The non-steroidal anti-inflammatory drugs blunt diuretic response by decreasing the prostaglandin synthesis and decreasing the renal blood flow. So decrease in the blood flow to the kidney decreases the diuretic response. Next, loop diuretics when administered with ototoxic drug exhibit additive ototoxicity. Because the loop diuretics can itself cause ototoxicity or hearing impairment when administered with ototoxic drugs such as aminoglycosides, there can be irreversible ototoxicity. Therefore, the administration is not recommended. Next, as we have learned earlier that the loop diuretics are secreted into the tubular lumen via organic anion transporter at the proximal tubule. Probenecid when administered along with loop diuretic binds to the transporter because it has higher affinity and thereby it inhibits the secretion of loop diuretics into the lumen. Therefore, this leads to accumulation of the diuretic in the body and a prolonged T-half. This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.